Hello. Yes, it works. Okay, let's get started. I would just like to say a few welcoming words on the occasion of this year's World AIDS Day, which you all know is under the theme Let Communities Lead. I'm happy to see so many of you here, new and old faces, students and volunteers and people who worked for ITM. So thank you very much for coming. I would like to introduce myself a little bit. My name is Christiana Nöstlinger. I'm trained as a health psychologist, and I work at ITM in the HIV and sexual health research group. And I'm a senior researcher in the HIV field, to say it very shortly. And I work at ITM since 2005. And when I came here, I was very impressed to see the working of the HIV-SAM project, which was, and still is, a dedicated sexual health promotion and HIV prevention project for people of sub-Saharan African descent living in Flanders. But let us also remind today that HIV was identified actually 40 years ago, and ITM was also among the first institutes in Europe that recognized the heterosexual HIV transmission, and also what later evolved into these concentrated epidemics among specific key populations. Hence, these efforts to address these specific populations. So for this group of people with originating from sub-Saharan Africa, the HIV-SAM project from the very beginning on used a community-based and participatory approach. And you will hear more about this later from my colleague Charles Dungo. The fact that this HIV-SAM project, due to a political decision from the Flemish government, starting next year will be merging with SENSOA, the Flemish Expertise Center for Sexual Health, has actually triggered our idea to organize this event today, to kind of showcase the achievements of the HIV-SAM project, but also to reflect on how to sustain a peer-led approach in the future. And also, of course, to thank the team of the HIV-SAM project for their continuous effort and their work, their hard work throughout many years at ITM. More generally speaking, the aim of this event today is to have an exchange on the importance of community-led and peer-led approaches. We will have contributions from Belgium, but also from international students, because we believe that in the global north, we can actually learn a lot from such initiatives in the global south. So why is a peer-led approach so important? Despite the substantial progress that we have made in HIV, in a world that is really marked by intersecting inequalities, not everyone is actually benefiting from advancement in treatment or, for instance, the biomedical prevention tools that are available. Yesterday, at the Belgian HIV conference, for instance, we learned that Belgium has reached the 95-95-95 targets set out for 2025, but only if we look at the general population of people living with HIV. Certain key populations, such as migrants who come from high endemic regions, are left behind. And we have also heard yesterday that there are two groups where HIV is increasing, and these are women of sub-Saharan African descent and young men having sex with men, both Belgian and from Latin America. So indeed, key populations, and particularly those who may belong to two key populations, for instance, or multiple key populations, continue to be disproportionately affected by HIV. On a global level, in 2022, The HIV prevalence among gay and other men having sex with men was 11 times higher than in the general population, 4 times higher among sex workers, 7 times higher among people who inject drugs, and 14 times higher among transgender people. So you can see how these groups are affected. Key populations are particularly vulnerable to acquire HIV because they belong to racialized and sexual minorities or otherwise marginalized groups, and they have often witnessed stigma and discrimination in the healthcare sector. So it is crucial that these people and communities can actually trust the services offered and that they can access these services free of stigma and discrimination. So according to UNAIDS, community-led organizations have actually become the backbone of the HIV response because they advocate for people's rights, they make sure that people can access these services, and they hold health systems accountable. And community-led organizations have actually started to provide differentiated HIV services and people-centered services before the public health sector did. And we know that today alliances between community-led services and the public health sector are recognized as a very effective approach in tackling HIV. So having said that, as a kind of little background information, I will just not really walk you through the program because this would take too much time, but I would just like to say that we're happy to have very interesting examples of peer-led and community-based initiatives, as I said, both from Belgium, from our HIV clinic, and also international experiences. And I would like to, of course, thank all the speakers who are here today for their contribution. It's really appreciated because we know, especially for the students, these are very busy times. And also I would like to thank the people who helped organize this event in first place, Gert and also Sabine. So we will go through the presentations. If time allows, we will have questions and answers after each presentation. But we have a very full program, so we will have to be strict in timekeeping so that each speaker also can really have their allocated time. So after the presentations, we will still have some time for more debate with you, the audience. Then there will also be a reception, which takes place in Caribou, so not here, but across the street for those who don't know. And then I would like to finish off with asking you to switch off your phones. You also know that the toilets are downstairs, and in case anything should happen, the emergency exits are there. So now let's get started with the first speaker. It's a co-presentation by Tom de Croo and Ibiloye Oluyudwon. I would briefly like to introduce you. So Ibiloye is a medical doctor from Nigeria. He provides technical assistance on HIV service delivery to key and vulnerable populations, including adolescents and young people in Nigeria. And he's currently a PhD student in the HIV and TB unit and at the University of Antwerp. And Tom de Croo is a medical doctor. He has worked extensively in Mozambique and also for MSF. And to roll out antiretroviral therapy, he designed together with patients a community-led initiative or a delivery model. And now he's a senior researcher at ITM, and he's passionate about working with master and PhD students. So the floor is yours. Thank you very much.
Good afternoon, everyone. But permit me to stand on the existing protocol. And then I am grateful for this opportunity to make this presentation, which I am co-presenting with my supervisor. So I'll be I'll be presenting to you the global HIV situation and the significance of community-led responses. Yeah, thank you. As at the end of 2022, 39 million people were living with HIV globally. And we know that the UNAIDS target to end HIV/AIDS by 2030 expect that at least 95% of people living with HIV would have been tested, and that 95% of people living with HIV are initiated on ART, and 95% are also very suppressed. And how did we fare as at the end of 2022? Of the 39 million people that were living with HIV as at the end of the year, 86% of them knew their HIV status. And 76% of them were initiated on ART. And of the 39 million people living with HIV, 71% of them were virologically suppressed. And then when we look at the new HIV infection, since the start of the epidemic, 85.6 million people have been infected so far. And looking at 2022 alone, globally, there were 1.3 million new HIV infections. And sub-Saharan Africa accounted for more than 50% of these new HIV infections. 500,000 in Eastern and Southern Africa, and 160,000 in Western and Central Africa. However, when we look at the trend of new HIV infections from 2010 up until 2022, there was significant progress made globally. At the global picture, there was a drop in annual HIV infections of 38%. Meanwhile, in Eastern and Southern Africa, new HIV infections dropped by 57%. But this is not the case in Eastern Europe and Central Asia, where there was an increase by 49%. And Middle East and North Africa, there was an increase of 61% during that period. And then looking at AIDS-related deaths, since the start of the epidemic, 40.4 million people have died from AIDS-related illnesses. However, with the introduction of antiretroviral treatment, which has been found to be very effective, we have been able to avert 20.8 million AIDS-related deaths, which is quite huge. And it's quite an achievement we should all celebrate. The United Nations Program for HIV and AIDS control put their heads together and identified a number of interventions, especially in countries that are doing well. And they have made a proposal that if these interventions are adopted, then we will be able to fast track achievements of the UNAIDS 95 by 2025. And one of these interventions being proposed is engagement of affected communities, and which is the theme of this year's World AIDS Day. So what do we mean by community-led AIDS responses? Community-led responses are actions and strategies that are aimed to improve the health and human rights of their constituencies, that are specifically informed and implemented. Let's take note of the keyword by and for the communities themselves and the organizations, groups, and networks that will represent them. So to showcase community-led AIDS responses, we will share with you case studies from Nigeria and Mozambique. So I will start off with the Nigerian example. Nigeria is the most populous country in sub-Saharan Africa, with a national HIV prevalence of 1.5%. However, in the Nigeria context, same-sex, sex trade, and drug use are criminalized, and it's a punishable offense that attracts imprisonment, minimum of 14 years for homosexuality. And within the healthcare facilities, there is stigma and discrimination that prevents members of key populations from accessing HIV care and treatment and services. So the country as a whole, through the Federal Ministry of Health and through the National Agency for the Control of AIDS, made a recommendation for community-based HIV approaches. That is to decentralize ART services to the community for members of key populations. And the key populations we are talking about are the sex workers, people who use drugs, men who have sex with men, and transgender people. So how has the country been able to operationalize this recommendation? So first of all, there was a contractual agreement with KP-led community organizations in the country. And with this, they are empowered to provide services to members of to key populations living with HIV. And the first thing the community-led organizations did was to recruit people from key populations community as community mobilizers and as peer educators. Community mobilizers are responsible for mobilization of KP community for HIV service delivery. And they also work as peer educators to educate them on the need for HIV treatment and prevention. Also, they built the capacity of community-led organizations as well as key populations that are working with the organizations to provide services. And then as part of the capacity building, their capacity is built on how to conduct hotspot mapping to identify locations where we have the most people from key populations, as well as how to go about sensitizing members for HIV testing and how to counsel them about the need to initiate antiretroviral treatment. And also, the community-led organizations, the representatives of community-led organizations, and members of key populations that are providing services within the community are invited to planning and review meetings, which is held regularly, where they provide feedback on their activities in the community and how best to improve on HIV service delivery. So specifically, Benue State, Nigeria, is one of the states that implemented community-based HIV service delivery. Benue State happens to be the second, state with the second highest HIV burden in the country. And within the state, we implemented 3 different approaches. The first approach is community-based health center, which is also known as one-stop shop clinic. The community-based health center provides comprehensive HIV services to members of key population, be it MSMs, be it female sex workers, or people who use drugs. And then we also have community drop-in center, which is like a mini one-stop shop. It is a safe place within the community where members of key populations can come to socialize and also to access HIV services. And finally, we have outreach venues. And these are designated places within the community that is served by a mobile health team from the community-based health center. The mobile team comprises of a doctor, a nurse, a pharmacist, and also a laboratory officer who provide services within the community. And then looking at the steps along the cascade of care for HIV service delivery, we identify the different activities or the different roles the community members are playing along the cascade. In the first 95, which has to do with testing, they help with mobilization of members of the community for HIV testing. They are also empowered to offer pre-test counseling, pre-test information, and actually do the testing. They identify cases of gender-based violation and make appropriate referral, and then symptomatic and screening for tuberculosis. They also raise awareness about pre-exposure prophylaxis. And then in the second 95, they assisted with antiretroviral refill for their members. They offer, they remind members about their appointments for ART. And they also participate, or they also help to track clients who are lost to follow up. And then for virological suppression, the 95, they also remind members about their viral load test appointments. And for those who are not virally suppressed, they also provide services to support enhanced adherence counseling. And they also organize support group meetings. So through collaboration with KP community, it has improved access to HIV service delivery in the country and in Benue State specifically. However, there are challenges. First is the issue of stigma and discrimination in the country, both in the community and in the healthcare facility. And this is preventing members of key population from accessing care and treatment in the community-based models. And also the criminalization policy, which empowers the law enforcement agencies to actually arrest and imprison members of key populations in the country. And then the technical ability or the capacity of the KP-led organizations and community members working within the organizations to actually provide services. We feel they are not, some of them do lack the capacity to provide these services, and there's need for training. And then the program is largely donor dependent, and sustainability becomes an issue. However, moving forward, we think there is need to create an enabling environment for members of key populations to access services and for the community-based HIV initiatives to see how it can be integrated into the national health system and the local health system as well. And of course, community empowerment to provide services. So thank you for your attention.
When we speak of community participation, I think sometimes we use this term for a vast range of different levels of involvement of patients and or communities. Sometimes we speak of community participation just because we inform patients what they are supposed to do. And then we say, look, they're participating. Sometimes we go a bit further and we say, we ask them, how should we best deliver our care to make sure that you indeed use our services? And sometimes we go a bit further, like in Nigeria, where there's indeed a collaborative approach where both patients and communities are joining. But ideally, we should go, I think, one step further and really empower patients and communities to join the effort and to contribute to HIV control, and whereby we involve them from the start in the design and not only when problems emerge. I will give an example from rural Mozambique from some time ago, but I think still relevant to us. I think when HIV care was being rolled out in Mozambique, there were many challenges with the health system, delivery of HIV care at every level. The coordination was almost non-existent. Here you see a health facility, which of course had a very, as you see, a very poor infrastructure. There were almost no nurses or doctors available, especially in the periphery. And clinics were very busy with long queues. And for those providing the care, was hardly any training or mentorship. So in these circumstances, we also wanted to save lives of those living far from the cities where the HIV clinics were being situated. And we created a model in which we involved the patients for some medical activities. So they formed groups called community IT groups, and they met once a month, and they organized themselves to assure refill of treatment within the community, to report outcomes to the health facility, and to refer those who were sick to the health facilities. In this way, we separated clinical care from this task focused on keeping people on treatment. Patients were motivated because they had all their own unmet health needs, and also the providers were motivated to join this effort because, of course, the less patients in the queue, the less work for them. So indeed, it is possible to involve patients in medical care. And then the question comes, should we pay them? Yes or no? But if at first involvement is also triggered by their own unmet health needs, patients sometimes can also join such efforts driven by such needs. And they can also add their own expertise of living with HIV to the activities to be enrolled through and within communities. And not to forget, if people join efforts, they can also share their knowledge, but also be triggered and be more motivated. This activity started in rural Mozambique, and sometimes we had groups of about 20 patients, of whom one person would go to the clinic and go back home with a bag of pills on top of her head or his head, and then deliver the pills at home like as if it were a small community pharmacy. It was very informal. It was, there were no rules at all. So we could say that there the ownership was very high. It was really driven and led and put in place as it worked, based on how people thought it would work best. All type of patients could be included, patients who just started ART, who were stable on ART, or also those who still had to start ART. Then, of course, we reported about the good outcomes. The retention was very high because, of course, nobody can be lost to follow-up if you are taking care of your neighbor. You know if a person has died or is looking for care elsewhere. But as this experience had to be translated to a policy and became provider-led, suddenly there were some rules. Each group could not have more than 6 members. Patients had to be stable on ART for at least and be on ART for at least 6 months. So the level of ownership and empowerment went down as this kind of bottom-up activity was translated to national policy. So I think there are some barriers to engaging communities and patients into HIV service delivery. Sometimes the policies that we write or that we push to make sure that we leave nobody behind might be, in fact, between us as providers and the patients we wish to serve. There might also be a lack of leadership. And it's also important to understand the power dynamics. It's not always easy for a nurse or a doctor to lose control and to share the power with those who they serve. Also important is to consider if you want to engage patients or communities, it's important to understand the local setting, to understand who are the stakeholders, who are the decision makers, and to understand the level of social cohesion on which you would like to build your activities. And of course, all comes with resources and funding, even if you want to build your activities on the patient's own time and energy. As a final slide, I think it's good for us to think about how we can reach and also sustain the 95, 95, 95. Ibeloy showed that we're indeed reaching those targets, but it's yet unclear how much communities and patients are contributing to what we've done so far. And it's also unclear how much we need them to meet those 95, 95 targets and also sustain them. What we have shown, I think, with different examples, and also today you will notice that indeed community participation and patient-led activities can be very effective. However, when do we consider engaging communities and patients? Only when we fail, when we are having too many patients lost to follow-up, or can we start from the beginning, when we design our activities or our programs and truly engage them and ask them what should be done and how care should deliver and which role they can play. So as Ibeloy has shown, activities can be along all the different steps of the cascade, but sometimes this is very fractioned and activities are only for one of the 3 pillars of care. So I think communities, of course, can build or can link those different pillars and make sure that the whole cascade is taken care of. And I think we also have to ask ourselves if indeed there's an important role for communities, how can our policies, instead of standing in the way of community participation, how can they in fact enhance such participation, taking into account that of course it will not be a one-size-fits-all approach, that every community, every subgroup is different, and that it will also require some flexibility from our end to monitor and support such community-led systems. Thank you.
Okay. Thank you very much, Tom and Ibeloy, also for your interesting reflections and questions. So I think we have 2 minutes for questions from the audience, either for if you have questions or clarifications or just some contributions. So any questions? Geert has the mic, so please speak up.
Just wait for with the previous goals for 1990 and now it's 95. Is there a previous is there a different approach for that? Did the strategy change?
Please, can you repeat your question, please? Yeah, I think there has been a number of changes along the line because as we implement, we are learning as well. And if you recall, one of the slides I showed, it shows the building blocks to fast track attainment of 95, 95, 95. And one of the building blocks has to do with community participation, which is not totally new, but then it needs to be strengthened. And then within the community-led response, the community-led monitoring is coming out strongly as well, whereby members of key population, whereby affected communities are participating in data collection, and they are making the analysis and reporting back to policymakers on what they want to be changed, as opposed to the normal service delivery data. So we have data coming from their hand that is complementing. And then there are a whole lot of other things going on. For instance, focusing on populations that are most affected, adolescents, young girls and women, for prioritizing them, prioritizing key population sex workers, female sex workers and transgenders. I think those are some of the strategic shifts which I think we help to hit the 95 target in the future or by 2025. I don't know if Tom will want to complement that.
Thank you for the first presentation. I just have a few things that I need clarification. One is on the community mobilization of the people for testing. How is that done? Do you look at data and you look at, when you look at the data, you say, okay, this number of people are positive and most of them are coming from area A, and therefore we need to target that so that you try to improve on the yield concept. What about the issues of quality of the testing that is done in the community? Why this? Because I come from South Sudan, and one time we, went out, to the community. We started the concept of community testing. When we subjected the testers to quality assurance, we sent blind samples, for them to run as if they're patient sample. And then we realized there was a bit of low, there were issues to do with the results that they issued out. So I think it would be good to learn from you what Nigeria probably has been doing in terms of quality assurance of the community testing component. And the last question is on the 95, the third 95, which is the viral load suppression. We tried to do what we call community viral load sample collection, because clients were not coming to the facility, and therefore we're giving the service to them, and that helped us improve on a little bit of the coverage. So for your case, are there modalities in place to enhance coverage? Thank you.
I hate to do this really, but we have to be short with the questions. So thank you.
Okay. So thank you for your questions. So for community based on HIV testing and case identification, I think the first thing the country did was to invest in the hotspot mapping and the KP size estimation. So with that in place, we are able to tell the exact locations where we have the most number of key populations for intervention. And also with the KP-led organizations on board and KP members conducting or providing services. So through snowballing, through respondent-driven approaches, they are able to reach out to their members and convince them to take up HIV testing services, and afterwards refer positive cases to community-based ART locations for ART initiation and subsequently refer. And then to your question on the viral load, yeah, most of the activities are happening in the community. For instance, the outreach venue that is served by mobile health team. So the mobile health teams goes to the community with all their gadgets, and they actually bleed clients in the community, do the initial centrifuging, and then transport the samples to the laboratory for testing. Okay, I guess did I miss anyone out?
Okay, thank you for being short in your answer, because we really have to watch the time. So we would like to continue with the global perspectives. And now we have 3 MPH students, 2 will speak here, and one, the third presentation will be a recorded video presentation. So I would like to first introduce Siku Kwananzi. She's a MPH student this year, but she's also a highly passionate researcher with public health expertise. With more than 10 years, you are working in that field, and she's dedicated to understanding and addressing the social determinants of health within key populations. And she will present to you an initiative among sex workers and also the related research that was conducted in Zimbabwe. Okay, so the floor is yours.
Hi, everyone. I'm quite short. Thank you for this platform. I'm going to talk about peer-led initiatives among sex workers done by SESHA Zimbabwe. It's a Center for Sexual Health, HIV and AIDS Research. So basically, SESHA is an organization that houses several HIV and AIDS prevention, sexual health programs, as well as offering clinical support to key populations, especially sex workers in all forms. Because in Zimbabwe, they are a vulnerable population, they are criminalized, they are a hidden population, it was very important for SESHA Zimbabwe to put them or to create a platform where I can say it was sort of a safe haven for them. It's a home for them where they can get services that they want. SESHA collaborates with local and international partners. It has MOUs with the Ministry of Health and Childcare. It also works with the National AIDS Council. And internationally, it collaborates with Liverpool School of Tropical Medicine, Institute of Tropical Medicine in Antwerp, as well as other international institutions. I'm going to talk about peer-led microplanning. This was a model that was initiated in 2019, where a cluster randomized trial was conducted. It was titled Differentiated Prevention, apologies, it keeps moving. Differentiated prevention and care to reduce the risk of HIV acquisition and transmission among female sex workers. It was an amethyst study. So with this study, 22 sites were randomized, 11 were the control and 11 were the intervention sites where they were implementing microplanning, and also self-help groups were part of that. So I'm going to briefly explain what we mean by microplanning. Microplanning means planning using information at the lowest level. It's basically being deliberate in giving peer support. So by micro-planning, we're saying regular peer support is offered to sex workers. Then peer supporters, they're fellow sex workers, they're called micro-planners or empowerment workers. And you'll find that in this presentation, I'm going to use the words interchangeably, but they are basically the same thing. They get a monthly incentive, they are volunteers, they get a small monthly incentive to motivate them, which you see is also a challenge because it's not much. Then the idea behind this model, it was to reduce risky behavior among female sex workers. So as here we're talking about HIV prevention, we're talking about HIV treatment, we're talking about reducing STIs and all those other things. And it's also to encourage sex workers to access clinical services, because a lot of the times, since they're stigmatized, it's so difficult for them to go and get clinical services in the hospitals or in the clinics. But when they visit SESHA clinics, the clinics are specifically for them, so they don't have to go to be worried about discrimination or being stigmatized. And then the other reason was for sustainability among sex workers beyond program funding, because we rely mostly on donor funding. So if funding ends, it means all these services are no longer provided. But within micro-planning, the model was so that even after the programs have ended, sex workers are able to sustain or to move forward. How micro-planning is implemented. So the micro-planners or the empowerment workers, they do a risk assessment. Because micro-planning, each individual sex worker has different needs. We are not the same. So they are being tracked by, the sex workers are tracked by micro-planners according to their risk assessment score. On the following slide, this is the risk assessment tool that they use. So we look at 6 things: the age of the sex worker, how long they've been in sex work, the number of clients that they have per week, inconsistent condom use, problematic drug or alcohol abuse, and also violent behavior. All these 6 are used to look at the risk score. So a low risk score is 0 out of 6. And a person who has low risk score is tracked once a month. And then a person with medium risk score, one who scores 1 or 2, is tracked every fortnight. And then a person with high risk score is tracked every week. So you see that the model is tailor-made in such a way that it's not everybody who's going to be tracked every week, or it's not everyone who's going to be tracked once a month. The role of the micro-planner, like I said in the previous slides, is to track the sex workers. So it's to recruit and support sex workers according to their needs, like we explained in the risk assessment. And then tracking cohorts using a hotspot diary. So when they do the risk assessment, they keep a track record of the sex workers they are tracking. Each micro-planner or empowerment worker has to track about 50 sex workers. So they will have a hotspot diary that is information for all those 50. So you'll find that because the micro-planners, they are part of the community, they are part of the sex workers, they are people that can be trusted, that sex workers are comfortable talking to. They will, they know what each individual in their cohort is supposed to get, the type of services that they're supposed to get. So each empowerment worker receives technical training on self-help groups. And these self-help groups, they groups that they're supposed to create within their cohorts, where they offer support, supporting each other. This could be adherence support on taking medication, encouraging each other to get tested for HIV, or encouraging each other to go and get other clinical services. So the microplanners cascade their training to the sex workers or to the members of their self-help groups. This could be between 12 and 15. So self-help groups are aimed to build social cohesion as well as psychological and financial resilience among sex workers. They are also, the members are trained on legal advice, financial literacy, conflict resolution, governance, stigma, and discrimination. And because we realize that in Zimbabwe, among sex workers, they don't have the same level of education. So it's important to have someone who understands them, who cascade these trainings and also make them understand. When they're doing the self-help groups, for example, they need to know how to handle money or how to do their budgets or even how to governance within their group. So these are skills that they are taught. That's the support that they also get. So the microplanners, like I said, they help establish these self-help groups, and they also encourage regular meetings between the self-help groups. When they're doing the self-help groups, sometimes they need to look for people that they have similar interests. So you'll find that sometimes we have young people forming a self-help group on their own, older people on their own, sex workers who are bar-based on their own, or sex workers who are track-based on their own. There are different projects that they are doing. They are rearing chickens or rabbits. Some are involved in detergent making. Some are also part of the ISALs. The challenges that affected the self-help groups not to reach their full potential. COVID-19 in 2020, the country was on total lockdown. So we will find that sex work generally was so difficult to do. The clients were not moving, the sex workers were not moving, there was no business. And even doing because the money for their capital, they'll get it from sex work. And the self-help groups are not that they stop sex work. They are just alternative financial means. So during lockdown, it was so difficult to do this. And then, like I mentioned earlier, the different education levels meant different levels of understanding. They'll get training on a particular topic and not get it well, and it will affect how the self-help group grows. And then also sex workers are highly mobile. They're very nomadic. So it's for them to stay at one place or to sustain a self-help group becomes difficult. The group will be 12 maybe at the beginning. When you check after 3 months, maybe only 6 are still in that particular area. And then lack of capital to do big projects. So growth is slow because, like I mentioned, they were sourcing their own capital. It was not funded in any way. Thank you.
Thank you very much. We will take questions afterwards. And now I would like to invite Mele Gondwe from Zambia. She's also a public health, Master of Public Health student this year, but she's also a social and behavioral scientist at SAMBART in Zambia, which is a non-governmental organization conducting multidisciplinary research in the field of HIV, TB, and sexual and reproductive health. And she will talk about experiences with adolescents and young people's support programs. Thank you very much.
Okay, thank you. So I'm going to talk about the lessons learned from the design and the implementation of community-based, peer-led sexual and reproductive health services in Lusaka, Zambia. So Yatu Yatu means for us, by us. So this was a cluster randomized trial of community-based sexual and reproductive health services for adolescents and young people aged 15 to 24. So this was conducted in 2 Zambian communities, and it was conducted from 2019 to 2022. So its primary objective was to evaluate the impact of this model of delivery of services on the knowledge of HIV status among these young people. Can this model of distribution increase knowledge of young people, HIV status among these young people? So the communities were divided in 20 zones and allocated to the intervention as well as the control arm. So each community had 5 intervention zones and 5 control arms. And in order to encourage these young people to access services in these communities, prevention point cards were integrated into the study. Now, how was this study designed? So this was co-developed with young people from these 2 communities in a formative study, and qualitative research as well as discrete choice experiment methods were done. So basically for qualitative research, we wanted to find out where would these young people want to access these services from? Who do they want these services to provide? Which people do they want these services to like the people that they want to deliver these services? And we also tried to get their opinion on the prevention point cards. What do they think about them? What information would they want these prevention point cards to contain? So for the qualitative participatory methods, focus group discussions, observations, as well as interviews were conducted. So at the beginning, as part of the community entry, community mapping focus group discussion were conducted in order to understand the context of these communities, as well as the places where these young people are mostly found. And then next, community observations were conducted in the community spaces that were identified during the community mapping focus group discussions. And we wanted to explore more in these spaces. What do these young people do? And one of these spaces included the health facility observations, just to understand how these services are delivered at the health facility. During the observations, participants for the primary discussions, the community focus group discussions, and the in-depth interviews were recruited. And during these focus group discussions, these core components of the intervention, where would they want these services to be provided? What type of providers? What do they think about the PPC card? And also their knowledge on the sexual and reproductive HIV services. Further, to consolidate the views that we got from these focus group discussions, ranking focus group discussions were conducted. And this is where now young people ranked the services as well as their preferred location. And then after now gathering these views, they were presented to these same young people in workshops to now give a final view. How do they want these services to be provided, including HIV? So after doing this whole process, young people preferred community spaces. They also wanted peer support workers to provide these services. And though the prevention point cards was something that was new to them, it's something that they actually accepted and decided on the various rewards that they wanted to collect. And it was during these workshops that the young people actually suggested that a peer support worker be placed at the health facility in order to help with referrals from the hubs in the community. So now what lessons did we learn from the formative study? So we used deliberative focus group discussions and iterative process in the qualitative research. And this enabled researchers to clarify topics to these young people that were being discussed. And also involving the SAM participants in the discussion aided young people to actually actively participate and also understand the issues that were being discussed. Triangulation of data, because we used focus group discussions, interviews, and observations, researchers were able to focus on the main findings and actually inform the interventions. However, because of diverse views from these young people, it was difficult to actually harmonize these findings. And then ranking process was worked well when it came to them choosing a preferred location where these services could be offered. But because it didn't really work well with the services, and this was because they considered all of them as essential, and because some had limited knowledge of these services such as PrEP, so it didn't really work well in that ranking process. So from the information that was gathered, it fed now into the intervention. And this is what I would say the intervention looked like. So the first part there, those were the community spaces. This is where young people used to access services. So we had 2 peer support workers, a male and a female, who provided services at these community spaces. So these community spaces were in all the intervention zones. And then the peer support workers provided these services with the support from a supervisor. We also had a nurse who used to provide contraceptives to young people in each hub and would rotate. So some of the services that were offered were HIV testing, comprehensive sexuality education, STI screening, condom distribution, and for some other services, young people had to be referred to the health facility for further diagnosis and treatment. For example, information on pre-exposure prophylaxis was offered, but we were not giving pre-exposure prophylaxis at the community spaces. And so if a young person requested for that, they had to be linked to the health facility. And sometimes the peer support workers facilitated referral to the health facility together with the peer support worker who was stationed at the health facility. And then what you see there, the Yatu card, that was the prevention point card. So at the beginning of the study, these prevention point cards were given to AY adolescents and young people that consented to take part in the study. So if they agreed to take part in the study, they would be given this card. So both the intervention and the control group were given this card. So the intervention people would access services at the community spaces, and the control group would access the services at the health facility. And so once they access the services, they would then gain rewards, which they would now redeem for, they would gain points, which they would now redeem for rewards, different rewards. Could be toothpaste, notebooks, soap, pens. So this is how the hubs looked like, the inside and the outside, just some of the hubs. These are the peer support workers that delivered the services. These are this is the prevention point card. It had a unique barcode. It had no name. And these are the services that were offered. So during the implementation of the study, COVID happened, and so some of the adaptations had to be made. So the hubs were closed for 3 months, and some of the adaptations that were made were that now how do the young people access these services? They're not going to the community spaces. So introduction of the WhatsApp group where they could access comprehensive sexuality education. After the reopening of the hubs, measures were put in place in line with the COVID measures. A number of people accessing the services were restricted. Now, did they find this intervention acceptable? So nested within this study was the qualitative component, which explored their perception, the acceptability of these studies, and they found these community spaces conducive. And because they were located in the communities, it was easy for them to access. And this is where they could get also HIV as well as pre-exposure prophylaxis information. However, there were some barriers, closure of the hubs, of course, and because we're providing condoms, social and cultural issues came up, and that affected access to the services. So in conclusion, though there were different views from young people during the design, engaging them at the very beginning to help with the design of the intervention was practical. And this actually supported the design and also informed the key components of the intervention. It was acceptable, and the cross-sectional study that was conducted in 2021 to actually estimate the knowledge among young people, HIV status knowledge, showed that there was an increase in the knowledge of HIV status among these people. However, this was a project, and so when it ended, the hubs were closed and young people had to go back to access the services at the health facility. Thank you.
So now we will have a recorded presentation from Nini Toon, who is a medical doctor and also a PhD student with Tom. And she unfortunately cannot be present online because we just heard that she has like a medical urgency. But she is working for Medical Action Myanmar, and she's also a researcher at the Myanmar Oxford Clinical Research Unit. So let's see if that works. Oh, really push it? No. Okay.
Hello everyone, my name is Nini. Today I'm going to present HIV and hepatitis C treatment outcome. Among the people who inject drugs, they were treated in HIV and hepatitis C services integrated with harm reduction in northern Kachin State, Myanmar. First of all, I would like to go to the disease burden among people who inject drugs in Myanmar. In Myanmar, HIV prevalence among the people who inject drugs were highest with 19%, while in the general population, the prevalence is less than 1%. For hepatitis C, among people who inject drugs, the prevalence is 47.7%, in general population 2.6%. When we look at the HIV and Hep C co-infected rate among people who injected drug, it was 20.1%. In the country, there are about 55 million of people are living, PWIT are about 93,000 population. In terms of treatment achievement, according to national data, among PWIT, only 14.1% of HIV positive receive HIV treatment, and less than 1% of them receive hepatitis C treatment. This is our program in northern part of Myanmar. The population is PWIT population in that specific district is about 2,500 to 3,000. The total population is 91,257. So as a Medical Action Myanmar, we started HIV and Hep C integrated program for PWIT in 150 remote villages. The villages are small about 100 to 500 people living in each village, the poor infrastructure. So as you can see on the right side, the road and houses and the infrastructure is quite poor. So for patient, it's difficult to go to the medical services in the town or the clinic. So let's look at our HIV-HCV integrated program project infrastructure. So the right side at the top is our clinic. The bottom is our mobile team going to the villages. So in the town, we have a clinic with medical doctor, nurses, and counselor, who they have a regular online contact with hepatologists from Happy Free Foundation in Australia. So especially for hepatitis C case discussion and treatment initiation. And in that clinic, we have also small laboratory where we can do rapid diagnosis tests and some basic tests, including gene experts. In the remote villages, we have, as you can see on the right side, we have a Barricade Outer-led mobile team. They are going regularly, once or twice a month, and we have village station community health workers, and also we train peer educators who are living in the village. So they are providing, we call it secondary service prevention. They are providing community-based HIV testing, Hep C, Hep B, and TB screening. They are also providing sterile needle and syringes, and they also facilitating referral to the clinics. So this left side is a base in clinic in the town with the activity, and the right side is a activity in the remote community. So as I mentioned, in the remote community, we have mobile team member who do home visits, compliant assessment, side effect monitoring for those who are taking HIV treatment, TB treatment, and hepatitis C treatment. And the right corner at the bottom is a needle and syringe distribution box. So these boxes we keep at every community health worker houses. So these are the more integrated model of HIV and hepatitis C care. So this is just a sketch. When you look at the left side, we have a clinic and we have a medical doctor providing treatment and counseling, and then linked to the villages with medical mobile team. So medical mobile teams are doing on-the-job training, monitoring of community health workers and peer educator, and they are also doing mobile clinic, which means they go to the village and they also see patient in the primary health care, and they are also doing home visit. So by this means, we are linking with the community of people who inject drugs in the remote area. So, but in that remote area, we also put two healthcare services as a station. One is community health workers, and the other one is a peer educator. So they are basically doing community-based testing and needle and syringe distribution, and then home visit monitoring of the patient. So after years of experience, we look at a 1 year HIV treatment cascade. Okay, so we look at the January to December 2022. Our outreach team reached 2,358 people who inject drugs, which means that these people receive HIV prevention services, which means HIV higher education, needle and syringe distribution, community-based HIV testing, and condom distribution, and TB screening, hepatitis B and C, etc., etc. Among those, 65.9% we achieve community-based testing, and we found 10% HIV positive, and among those who are positive, 76.3% we can initiate them on ART, and among them we can do paraload for 79.8% of people who are on ART and eligible to do HIV paraload testing. We can do the paraload testing with gene expert at the clinic. Among those who tested HIV viral load, we achieved 90.1% virologically suppressed. We also look at hepatitis C treatment outcome among HIV and hepatitis C co-infected people who inject drugs. We found that 89.6% completed treatment. So those people, they completed the whole treatment. For hepatitis C treatment, we use sulfose and Douglas. We use a duration 12 weeks and 24 weeks. So people who has no fibrosis, we use 12 weeks regime, and who has fibrosis, we use 24-week regime. So those people, 89.6%, they have completed hepatitis C treatment. And we look at the patient who has completed treatment and also has parallel testing 12 weeks after completion treatment, and we found that 83% 10 hepatitis C negative. So we define as cure. We also look at people who are cured on the treatment. We also look at 1 year follow-up. And we found that 32.5% 10 hepatitis C positive among those who came for 1 year post-treatment follow-up. As a conclusion, so community-based providing of HIV and hepatitis C integrated services is possible in very remote area in northern district in Myanmar. It improve HIV and hepatitis C treatment update. During the 1 year follow-up on among the cured patient, we found that 32.5% 10 hepatitis C RNA positive. However, we do not do a proper recording. Unfortunately, we do not have a proper recording of injecting risk behavior to see whether it is reinfection or relapse. And also, we are not able to do genotyping or deep gene sequencing. Therefore, we could not distinguish reinfection from relapse. And thank you for your attention.
Okay, so I think although we are running late, we may have time for 1 or 2 questions. So if there are any questions, please shoot. No questions? Oh, there's one here.
So my question is for Siku. I just wanted to understand. I was assuming that some of the sexual commercial sex workers might not be positive for HIV. So how was your program targeting them, or were they left out? And if the program included both of them, then how the issue of confidentiality and ethicality was handled?
Thank you, David. So the program was targeting sex workers, regardless of your status. Getting tested was part of the services. You get tested, you're initiated on ART. If you're positive, if you're negative, you're encouraged to get PrEP. And the issue of confidentiality is the same way we would handle it even in a conventional health facility. So when we're doing the self-help groups, we are not talking about HIV positive or negative. We're talking to high-risk females who sell sex. I hope I've answered you.
Thank you. My question also is for Siku. I ask about if you have, do you have a vertical program concerning, of course, HIV in your country, and how is it concerning the reachability, the accessibility of this key population as sex workers?
Okay, thank you. So there are vertical programs in the country concerning HIV. And when we are talking about key populations, because they are criminalized, it's not just sex workers. It's not just female sex workers. It's male sex workers, men who sleep with men, transgender sex workers. They are criminalized, so there is no program for them in the conventional, in conventional institutions. They cannot go to government hospital and get services. But within SESHA, there is some protection that is still there, where they can go and get services, they can go and get HIV treatment, they can go and get HIV prevention services. I hope I've answered you.
Okay, thank you very much. So now we change the scenery, and we move back to Belgium, and we also move to a more interactive part of this afternoon. And I would like to invite Cora Lamonte and Venne Mertens to come up here. They are both social nurses at the HIV clinic here at ITM. And next to their daily clinical work, they have developed many initiatives such as for psychosocial support, such as patient groups, and they are also very committed to fight stigma and discrimination. And each year they develop a World AIDS Day campaign, and they will present it now to you. Thank you. Please help.
Denk je, als je de volgende slides en dan... Nee. Ik had de laatste. Okay. First of all, thank you for inviting us to speak about our patient group and our campaigns against stigma. So you saw the picture already a few times. Our patient group is called VIVA. We started in 2008, and we started with small closed groups for women living with HIV. They evolved to open groups. And nowadays we have mixed groups, and that means that there are men and women living with HIV that can come to our VIVA group. So VIVA stood for Vrouwen met HIV in Antwerpen, so women with HIV in Antwerp, and we kept the name, but now it's Vitality HIV Antwerp. So, but we kept our name. So, yeah, in our group, we have men and women and all sorts of nationalities. We had 42 meetings in all those years, and 250 patients we've reached. Those patients, there's always a group of people who come always, and we have also always new people coming. So there are people who are new patients, there are people who are a long time in follow-up. So it's a really mixed group. We like to show you some activities we do with our patients to engage the group to talk about their lives with HIV. With their stories, they learn from each other's experiences and they recognize the issues, but also the strengths to deal with them. And this is one of the creative interventions we do, and it's called the Tree of Life. Every patient in the group has made a picture, a drawing of his or her tree, and it comes in phases. So we have the roots, and that's where are you from? The ground is the here and now. The trunk are our skills. We've got the branches that are the dreams. We have the leaves that are the important people. Fruits, the gifts you give, you have received, and the flowers are the gifts you give. Now, as you see, there are lots of examples. You see a tree, but you see a life, and you see the things they deal with, but you also see their strengths and also the people around them that help them. At the end of the day, we had lots of more of these drawings, and we've put them on the ground. We saw a little forest coming, standing against the winds or the difficulties in their lives. So that was one of our exercises. We did also a Radio Viva, that's storytelling also, but by playing music. We asked before we start, send us your favorite song. What song brings you comfort? What's a reminder of sad, joyful moments? So that day we were DJ Wana and DJ Cora. Sometimes we make our own dreams come true. So there are all, like exercises with people to talk about their lives. We have also done lots of meetings where we ask experts in HIV care. You see the topics like aging, menopause, mental health, disclosure, lifestyle, adherence, parenting. So we give also lots of information sessions where people can ask their questions, and it's provided by the experts in care. Okay.
Bye-bye. This is what we said to Stigma in 2019. And it was our first campaign 5 years ago against HIV stigmatization at ITM. We had large T-shirts like this one. Each year we have different outfits, this one. And we made them a lot smaller, just in paper. And we asked the Viva group to put messages on the T-shirts, on the back on the small T-shirts, and write down why urgently stigma should stop. This is an example. We didn't ask the group, just only the group, but we also asked it went much larger, everybody who entered ITM that month. We asked it to do to students, to ITM staff, visitors, and not long later, in no time, it became a big laundry. You see here an example in the clinic. People had written down all messages, and it was a big support for patient visiting the clinic because everybody could walk the corridor and saw what everybody wrote down as a support.
So then we had 2020 and there was COVID. We used the face masks you see there to spread our message, and the message then was let's talk positive, and the you is you message. The undetectable is untransmittable message. So here you see the students that year supporting our campaign. That's one example. There was not only COVID, there was also the Jerusalema. I don't know if you know it, but everybody in Belgium was dancing the Jerusalema and putting it on social media. So it was very nice to see. But we took this opportunity to make our point, and we're going to show you how we try to do that. So the clapping you hear and the laughing, that was our group, but we did it in another room, and we only recorded their voices, but they were really there. So we did the dance, and we did it also with our colleagues. It was very nice moment, but we couldn't show them. We can never show pictures because of the stigma. The year after, the next year, 2021, we did a special campaign because we saw and we heard in studies that even stigma in healthcare is increasing. And we found it very striking, and we thought we had to do something especially for healthcare workers. So at that time, we made some pins with the undetectable untransmittable message to wear at work. So the healthcare workers could put it on their white clothing where they walk along with. But at that moment, people with HIV could see that their healthcare workers, they knew about USU, they were well informed, and people could feel safe with them. So we distributed these pins to lots of hospitals, not only in the ITM, but USA, but all the hospitals we could reach in the Flemish region and also in Brussels. In south of the country. Yes, as much as we can. Yeah.
Okay. A smile that sticks was our campaign slogan last year. We used our USU smileys as stickers and removable tattoos to show that you can replace the negative stigma sticker by a positive message. USU with a double meaning again. The USU as undetectable is untransmittable, and the USU as an equality message. You is you is you. We are all equal. Stickers for mobiles, laptops, bicycles, etc., and tattoos, of course, on people. And in the summer, we went to Antwerp Pride Village, and we have also a little movie from that.
Love me, say
Last summer, we decided to do a walk with our Viva group in Antwerp. On one condition, it had to be safe for everybody. But what is safety? What is a safe space? We found a possible definition. A safe space is a place or an environment in which a person or category of people can be confident that they will not be exposed to discrimination, criticism, harassment, or other emotional or physical harm.
So we wanted to connect some of the safe spaces in Antwerp for our group. One of the safe spaces we hoped and we like to be is at the ITM, at the clinic. But we walked together to Sensoa because there's another safe space there. It's not the first time that we went out, but it's different than staying inside, because what Cora tells you about the safety is different when you go outside. With our new campaign, we want to connect lots of more of safe spaces for people living with HIV and creating even new ones, we hope. We've already spread 5,000 cards, and we hope that you also take them with you and spread the message.
So this is the walk to Sensoa. So there we were welcomed by two members of Sensoa, Patrick and Leen. And so it was a really nice ending of our walk of the day. These are some pictures how people can use our safe space cards. We did already a nice photo shoot with our director, Professor Dr. Lutlijnen. And you see also USA as our partner and ITM, of course. And now it's time for action. So it's your turn to join us to do the exercise that we did before we went for the walk with the group. So because we wanted to feel safe for everybody, we asked them to do an exercise about safe space, about where do you feel safe, with whom do you feel safe. And everybody got 3 things when you entered the symposium: a stilo, the white sheets, the worksheets, and the cards. So at the last, too late. So this is the sheets. So you have the cards. Take your time to take the cards and the stilo. So the idea is that you remove the middle, the blue clouds, and then place the frame on your worksheets. You can use the back of one of the people here when it's safe to draw down the clouds in the middle of the sheets. Or you can use just your own legs, of course. If it's not clear, you can cheat and look at a neighbor to see what he or she is doing. When you are ready, please raise the hands so that we know. Are you ready? Not yet. Okay. Is everybody ready? Yes? Okay. So now stop cheating. because it's really important that it's a safe exercise for everybody. So just look at your own white paper. When it is not safe to write, please just do it. Imagine a cloud that is safe to you, all right? Now, the first question, you can see it already there. Write in your safe space cloud people and places that feel safe to you. So you can do that now. Write down people or places that feel safe to you in the cloud. Okay, when you are ready with this, you can also write why you feel safe with that person and in that place. Why is that?
So now you've written down that feels safe to you. We ask you to write outside of the cloud people or places that feel unsafe to you. And while doing that, you can also think about the question, why does it feel unsafe?
Okay, the exercise is finished, but we are really, we are wondering how this was for you to do. So you don't have to tell us who is unsafe, what is safe, but we are curious to know how does this exercise feel to you? So is there somebody who can react on our question, please?
Thank you. I felt that during the exercise, where I felt safe had to do a lot with the people who are around me, because I could be in the same place and feeling safe if I have the people that I feel safe around me. But if I'm in the same place, but without them, it can still feel unsafe. So it had a lot to do with the people around me.
Thank you. Yeah.
I think for me, it made me think of the places I don't feel safe first to see what the difference is. And then I realized that even though I'm a woman, but otherwise I'm able to feel safe in most places. And I think that's also something I now realize that it's not the same for everyone. Yeah.
Thank you. Another question?
Thank you for this exercise. To me, it really reminds me of what people go through, particularly the PLHIVs and the issues of privacy, stigma are really very important. I have ever interacted with people living with HIV, and they said when they see my neighbor or my colleague, you know, seeing me being provided services in a facility, they feel completely uncomfortable. And therefore, providing services in a secure space is really very important. And importantly, with people who are able to maintain ethics, medical ethics. Yeah. And to be honest, I have put here that it is a safe space to me is being at home, where somebody comes to me at home, you know, or if it is at a facility, that facility should be secure. Yeah.
Thank you. It was a funny exercise for me, and it reminded me many things, not only for me, but as a doctor for my patients living with HIV. And during our interviews, for example, one day they said, one patient said me that sometimes he don't feel safe when she is outside. And outside means, for example, in the general population, and like her own parents. But when he is with her, for example, her friends living also with HIV, he can do anything, he can tell them anything, and he feel in a safe place with these people. Because in our countries like Africa, I am from Senegal, HIV is stigmatized. Yes, thank you.
Yeah, thank you everybody for the reactions, and especially the last one when we went outside with our group. The patients themselves, they helped each other. We went outside and we saw people were scared, like, oh, what if people see me, recognize me? Who is this group? Please don't carry the ITM badge, because then they can see we're just doing everything we could do to make it safe. But the patients themselves, they helped each other. So we went from togetherness, and then the group was getting a bit more alienated and things like that. But we came together, we came at Sensoa. But they helped each other. It's like a harmonica we do. We went like this and this and this, and they helped each other. They feel safe with each other, and that's what I hear here also. So thank you very much. Thank you.
So thank you very much for this self-reflecting exercise. It was really great. And now I would like to invite my colleague Charles Dungu to come to speak to you about the HIV-SAM project. So to introduce Dungu, he's an anthropologist and he coordinates HIV prevention within the HIV-SAM project that I told you about in the beginning. And he is, so within the HIV-SAM project, they have developed many interventions along the, let's say, HIV continuum of care. Dungu started out, for instance, with developing an intervention for people recently diagnosed with HIV to improve their quality of life, but he also coordinates outreach, community-based HIV testing, and provides psychosocial support to people living with HIV. So he will tell you more about the HIV-SAM project.
Yeah. Okay, I'll do that. Okay, thank you very much for the organizers, Health and Christiana. The third one is, I don't see a face, but anyway, thank you very much. So I will not take a lot of time. So I'm being given a very challenging task to talk about the HIV-SAM project because listen, in the audience, you have the founder, Bob is there, and of the project, and you have the veterans, Laurent and Lazare. So I feel challenged. But anyhow, so what I'm going to give is my own interpretation. So just, it's a presentation about the project, so not academic stuff or whatever. So it's just a story, okay? So, so just to give a bit of the historical context. So the project started in 1996 when I think HIV was first recognized. I mean, some years after HIV was recognized as a problem here in Belgium, and it was started as a community-based project using a targeted approach for people of African origins. By then it was referred to as Sub-Saharan African migrants, but I think we have changed a bit of perspective. So, and the project was embedded here at the ITM in the Department of Public Health. And the motive was that people of African origin were disproportionately affected by the epidemic. So why then this community, why these communities? African is not one community, the number, just an agglomeration of communities from different countries and different parts of Africa. So the first reason is, of course, the HIV prevalence, as you can see from the graph, that it's from the very beginning of the recording of the data that the people of Africa, Sub-Saharan origin, were the second affected by the epidemic. And then these were the other reasons that from the clinical data of people who are diagnosed late, from the studies that have been done, there was low risk perception. There was this saying, on a laissé le VIH en Afrique. So the people really thought there was no risk here in Belgium. So life went on as usual. And then there was also, which is, I think, most of us would agree that there is lower prevention behavior among the people who migrate to Europe. It's not that people go to see the doctor every year or every month. So, and then also the anthropological reason that there was at least need to have people, professionals with African origin, because they know the group better. And then also they need to give culturally sensitive support for people living with HIV. And then last but not least, to engage the communities in the fight against stigma, because this can only be done by and within the communities. So this is just the mission and objectives of the project, and this is the current team. So how does the project operate? So the project operates, as Christian said in the introduction, it's a community-based. So the approach is as much as possible participatory, but in quotes, because participation can be complicated. And we try also to use a culturally sensitive and context-specific approach to prevention and providing services and support to people living with HIV. And last but not least, we use the outreach approach. So outreach in the real sense of going towards the group. This is a video I'll not show, but you can access it afterwards. It's on our website, just talking about how we do outreach. So these are some of the pictures that show how we go in the communities and the bars, and what do we do there? Of course, the first activities, I mean, besides distribution of materials, raising awareness, there is the community-based approach, which was linked to the initiative of the HIV Clinic of the Swap to Know. This was the beginning of this taking the samples, the saliva samples for HIV indicative rapid testing. These are still some of the pictures of the outreach in the church. So funny that you can also do HIV testing in a church. So this is how, try to schematize how the project looks. So in the HIV-SAM project, we don't use the classical words of the target groups. So we talk about stakeholders. So you can see how it works. A number of people are involved in this service and prevention and support for people living with HIV. So you have the main community of interest, as I said, the African communities, and you have the intermediaries, among whom you have the community intermediaries, people in the communities, organizations, and individual volunteers. You have the professional intermediaries, which are people working, giving services to people of African origin, of course. And then you have also the people living with HIV who are main actors, not only to help each other live with the infection, the chronic illness, but also as active agents in prevention through their testimonies and raising awareness that you can live a normal life with HIV. So this is the complexity of our project, which I have had all my years of working here. Many people at ITM don't understand well. So you can have a look and see how it looks like. So just these are some details about the stakeholders and partners. So the community intermediaries, so we have a number of organizations. So we work, for example, the Congolese community organization called the Bilenge. The president is here. Levis, are you around? Yes. So then we work also with the Acacia. This is a community of people originating from Cameroon. We have the Edo Association, which is a Nigerian community, the Basibomuko in Ghent, the Edo community. You see, I talked about communities because it's complex. So we have an association in Ghent and we have a community in Antwerp. So they are communities, even Nigeria. So, and then you have the prevention network. We have at least 30 plus volunteers. We have organizations which work with us without a contract. And you have, recently we have also had, and this has been very hard work, some LGBTQ plus groups, Why Me, which is a kind of gay diaspora group. And we have also a group of transgender who are also in diaspora who call themselves For All Queens. Then we have also the churches. And recently we try also to work with the mosques. So this is just some of the pictures of our stakeholders, the community intermediaries. And here on your left, I think, is how the office of Levis looks like. So he has lots of flyers and then a condom dispenser. And here on your right, I think in the top, these are at least the recent group of the leaders of the key organizations. We had a meeting here. And these are the professional intermediaries, which I already talked about. But maybe to just mention that we have had a very important professional intermediary. These are the people who are working in asylum centers, where we have been recently to go and give a training to 40 nurses who are working in asylum centers. For example, how to introduce the topic of sexual health and propose an HIV test to the asylum seekers and the care for people living with HIV. And then we work also with the primary health care providers. My colleague Lazar and Christian have worked a lot to develop tools to help the GPs to proactively provide HIV testing to this key population of people of Africa, sub-Saharan origin. So it's online. And my colleague Lazar, he has worked, I think, a number of years with the Avon courses to it's a kind of course that he gave each year to HIV professionals on culturally sensitive approach to HIV prevention. And this is also a professional intermediary. This a very important one, the integration services, whereby the people doing integration classes bring their students either here or we go to the settings themselves to give an info session and provide a rapid HIV testing. And we have also recently developed a guidebook for the teachers to use, because with limited resources, we cannot be able to go to all the integration services scattered in the Flanders. So this is so this is just an example of how the class looks like. It's very So this is a teacher of integration services, and she's giving, based on our handbook, the session in Somalese. So I don't speak even a single word of Somalese. So if we don't trust people, then you cannot work in prevention. So I have no idea what she was saying, but she was explaining the importance of the female condom. So this is how we work: trust and let people do. So this is another very important stakeholder, as I said, the people living with HIV. So we have the group that founded by my colleague Lazar, the Muungano group, I think very unique group here in Belgium and the Flanders. And it has around 30 permanent members of people living with HIV. They meet once a month. They support each other, but they also do some other self-help activities. Then we also collaborate with the psychosocial support organizations. For instance, Living in Brussels. This is an organization that supports people living with the chronic illnesses. So they contacted us to give support to people living with HIV. Then we have also other groups, but we also have a workshop, as Christiana said, that an intervention that we give to people living with HIV, which is a session given in 4 days in 1 month. So these are just to make kind of schematization, the action domains of the project. So the co-development and implementation of intervention, the capacity building, and then some research, which is main activity of the project. So in the co-development of the interventions and their implementation and evaluation, there is, of course, the primary prevention for the classical way of saying, and then support for people living with HIV. So these are some of the pictures of the field, of the work in the field. And this picture on your right, I think in the bottom, this was the farewell of my colleague Lazar. So there was a big presence, as you can see. And the photo on your left, I think, is real field work in the city of Antwerp. This is still field work. This was an activity at the Koningsplein where I went and put a tent just to give information and then also invite people for rapid HIV testing. And this is how it looks like. This is a recent photo in last summer about distribution condom during a social event organized by the Cameroonian community or by the EDO Association. So capacity building is mostly in trainings, and this is for community intermediaries and also for professional intermediaries. So, for instance, the training for community intermediaries, for instance, about culturally sensitive communication, about sensitive issues such as sex and sexual health. The training in administration. So we don't take it for granted that people know how to do the simple reporting or how to use Excel. So our colleague Alexandra does this training. And we have also training for the community intermediaries and the volunteers in collaboration with the Help Center at our clinic here. So the volunteers are trained in demedicalized HIV rapid testing, which is indicative, and we really insist on that word, that when people are diagnosed reactive, so they have to be linked to care for confirmation test. So this is a recent training which took place last year. And these are still some of the pictures. Then last but not least, about what we do, these are the action research, the masterpiece of my colleague Lazar, a long research on the barriers to HIV testing in African communities, because it's not easy. So in the article, at least in the research, they identified a number of barriers. And during the COVID pandemic, we also did some studies on, for instance, the barriers to knowledge about HIV, COVID, not HIV. So can we talk of an impact? So these are some of the issues. It's very complex to talk about whether at all we have, over these 27 years, we have had an impact. I think we can only say with some nuances that maybe at least the condom is now normalized in African communities. So as you saw in the picture, it's no longer taboo. So people can have their condom in the pocket in order to have safe sex. Then there's also at least a considerable normalization of HIV testing. When we go to the community, I think, Lazar, it's easier than when you started, as you yourself know. And there is also a reduction of the sex taboo, which is very strong among African communities and other communities. And the participatory and community-based approach, which is not only in words, but which we actually do. There is still some things to be improved, of course. We have also fostered ownership of sexual health promotion by communities, although there is not enough recognition, and the funding is very meager, at least in the communities. There is easier mobilization in African communities, as we learned during the COVID pandemic. So the communities are easier now to go to, at least when you want to work together with them on other health issues, thanks to the HIV-SAM project. So the space has been created that communities are receptive to health promotion initiatives of other kinds. What are the future perspectives? Well, as I think Christiana said at the beginning, our project will be merging with the SENSOA next year. So the perspective, there is of course uncertainty. The questions about what will be the identity of the project within an expertise center for sexual health. How will our approach be preserved? And after 27 years of HIV prevention in African communities, this is just a question. Is this approach still relevant? I think the statement from Cienzano, the answer is affirmative, that I think the targeted prevention in African communities is still relevant, especially for women. And then last but not least, that as a perspective for the future, and this is a request from communities, that there is a request for broadening of the topics. So not only HIV or sexually transmissible infections, and less focusing on prevention, but maybe broaden to aspects of sexual health like gender, sexual orientation, which is still a taboo in African communities. So you just don't talk about it, that you have a son who is gay or transgender. So communities are asking that these aspects be integrated also in our approach. They have also requested for that we facilitate the communication on sex and sexuality between parents and their pupils, that we include aspects of sexual health like sexual violence. And this we are working in collaboration with, for example, the Center for Sexual Violence, which is at the new center at the University of Antwerp. Aspects like family planning, and then sex and religious worldviews, because this is mostly ignored, that when you talk about sex, at least for African communities, you cannot separate it from what people believe. So we have to find a way how to bring this also in picture. You know, it's very easy that we do prevention, but if we don't include people's worldview, I think the success will be very difficult. So with that, I will welcome your questions.
So thank you very much, Dungo. I think we have time for a few questions. So if you have some questions for Dungo or about the HIV-SAM project, please. So if there are no questions right now,
It
maybe.
was very clear.
Or maybe. I would now like to invite Sandra Sandenande. She's from Sensor. She's a policy advisor for sexual health and STIs, HIV, but she also coordinates the unit at Sensor that directly reaches out to vulnerable populations. She's also trained as a psychologist and sexologist, and I would like to invite you to talk about future perspectives on community-led prevention. Thank you.
How does this work? There might be something like that.
Just press hard or use the keys.
Okay.
Yeah, that's yours.
Here
or here. The big one.
The big one. Okay. Well, thank you very much for giving us the opportunity to talk a bit about the future, because these are real delicate times as well. And I feel a bit humble standing in front of you, of so many people with so many expertise in peer-led working towards target groups. And we've prepared a little introduction to Sensoa and the future. And we hope in doing so that it will lower the threshold a little bit, and that you will find us a worthy partner as your future basis to work from. Since I was told that the audience today would be very diverse, we took a bit of leap back into time for introducing Sensoa and what our work, where we come from. And in this slide, you see that we actually started working many decades ago. That's the bottom line of the slide, with different organizations working towards different target groups, the AIDS team, AIDS phone, the foundation specifically for people living with HIV, and the AIDS team for men having sex with men. And these organizations often sprouted from people from within the community themselves. So they were community-led organizations. And as time progressed and contracts became more officialized with governments, for instance, funding the work, Sensoa came to nourish and became the expertise center on sexual health. So we were born from community-led organizations and servicing communities ever since that day. So, and we still do. Today, we are called Sensoa, the Flemish Expertise Center for Sexual Health, and we have a mission. For Flanders, we promote sexual health as a center of expertise, and we do that in an international perspective. This doesn't mean that we reach out to other countries or go work in other countries, but what we try to do is that we influence our Belgian government when they collaborate with international countries, with other countries, that they take sexual and reproductive health as an important issue in their policies. So we start from a positive vision on sexual health and rights, which means, of course, you know this definition. Some of you know it by heart. It's the WHO definition on sexual health, and it starts from a positive angle. It takes a positive angle on sexual health. It's not just mere the absence of disease, of illnesses, or undesirable aspects of sex. It's got a positive connotation on sexuality, that it also involves being allowed to have pleasurable sex, respectful sex, and freedom to choose your own sexual relationships. So these are also the rights which we hold dearly to our hearts, that you are free to choose the partner that you want, the kind of sex that you want to start a family or not, and that you are free, of course, from discrimination and violence. That's our main vision on sexual health. How do we apply that in our work? Well, we do a couple of things. We develop interventions. Our main task is to inform, to deliver information or make information accessible on a wide range of aspects on sexual health. educate, so we train our professionals that surround target groups or target audiences. It is our idea that in doing so, we will reach even more people because these intermediaries or professionals reach, of course, in respectively more people in our society. Another part that we have come to do even more and more in the past decade is that we take on some advocacy work. And advocacy work concentrates particularly on removing structural barriers to having good sexual health. For instance, when services are not accessible for certain groups or non-existent, then we try to change that. Reimbursement, for instance, is limited, as some of you have heard me explain yesterday on the Breach conference, where we try really hard to remove those structural barriers. And we offer support, and this is the part in which we work very closely with our target audiences. For instance, with people living with HIV. People living with HIV can come to Sensoa and they are offered support. There's our service delivery of our two colleagues that you just saw also in the presentation of Wenne and Cora, that talk to people living with HIV and help them get on the road of their life again and organize activities. The other things that we do is particularly straight to target audiences is to men having sex with men. And I'll just come to that in a minute when I show some of our activities. Oh, this one tumbled a bit down, but where the frame had needed to be was around professionals and target groups with specific needs. So these are the ones that I wanted to focus on in the next slides, and that is we have different tasks that we try to deliver as well as possible, and the department that is most busy with reaching target groups directly, it's called that way, the rechtstreeks, is that we try to reach specific groups with specific needs in a direct dialogue. So we go out into the field and try to offer the best sexual health, be it prevention, in information or access to services to specific groups. And these are, in our history, are men having sex with men and people living with HIV. So it is to deliver prevention methods in the field and reaching these groups. It's not only physically, by going to bars, by going to prides, by going to saunas, by going to parties, but also online. Quite recently, we developed a method of reaching men having sex with men with online service, with being also active on dating apps and offering prevention information. We don't do that alone, of course. We work as closely as we can together with the professionals that surround the groups, be it the organizer of parties or the owner of a bar or other professionals or organizations that surround groups. And in doing so, we collaborate in a network. I hold a very, I really like our work directly to our target groups because it offers us a unique possibility. And I've already heard it a couple of times in the presentations. It's actually, you get the needs first-handedly. When you talk to people, be it on a very general topic as condoms or informing people on PrEP, you hear first-handedly what problems are, what issues, desires, needs are. And that's such a crucial part of working directly towards target groups, having peer-led activities within the core of your organization, because I always say that you've got your fingers in target groups. You really feel what is necessary and what is happening. And that is so necessary. I know that the debate was cancelled, but that was actually one of the questions of what is so important about having peer-led activities, and that is that you really feel what is needed first-handedly. So if I can answer by that a little bit, the uncertainty of what is the opinion about peer-led, well, it is very important that we remain doing that. As SENSOA, we have a bit of a double identity. Well, we are an expert organization, but at the same time, this kind of work of working directly towards target groups really helps us to deliver our role much better. So if you ask me, it would always be there. What are those main activities that we focus on? So we have a lot of similarities. We do develop interventions and products as well, directly and in collaboration with partners, but also with target groups. We do the outreach work, be it digital or physical, in collaboration with professionals, with volunteers, tailored to the needs. So we do invest a lot of time in knowing our target audience, being part of it, being part of networks where our audiences appear. And we also investigate our method. Is our outreach work still doing what it's supposed to be doing? Are we still delivering the best of quality of our work and what our target audiences need? And then the third part is the psychosocial support, which is particularly focused for people living with HIV. There are some other departments at SENSOA that are also involved in this integration that was mentioned, because there is no such thing as a small integration. And there's no such thing as taking over a task such as what HIV-SAM project is doing and putting it in one department and saying, okay, we're done. No, this is something that will affect us all, that will affect the entire organization, and we are preparing to do that. We are very prepared as well to let that happen. So all our departments are wanting to make this integration happen. We have one part that is focusing with a special expertise on working towards intermediaries that are professionals that are working for sexual and reproductive health and rights, for sexual prevention of sexual violence, sexual well-being, and sexual and relational educational. So we develop materials to help professionals that are working in those domains. There is a SENSOA Academy for professionals that develops e-learnings and webinars, and we are looking at how we can make that integration happen there as well and support all the materials that have been developed already by HIV-SAM. Another part of our work focuses on communication. As you know, or as some of my colleagues have told us, everything is communication. So all the work that we do, preferably we want the right people to hear what you have to say, and these people, our colleagues, help us deliver those messages as in the best possible way. Most common things that you know are our websites, but we also have specific websites for we're using as less language as possible and as much visuals as possible to explain sexual health, because we find it so important. And the advocacy work, I already talked about it a little bit. The part that is particularly important for our integration with the HIV-SAM project is that we are a part of the monitoring committee of the national HIV plan, in which we try to ensure that as much as structural barriers are released so that access to prevention and care for people living with HIV or for the prevention is accessible to all. Now, as I said, there's quite some synergy in our actions, in our activities, and in our vision. And I've also integrated some pictures of activities, and we have even the same picture there on the left of your activist where we have already been participating in each other's work. So for those who do not know us very long, so we have also already a long-standing history of working together in different activities. The people that you see there in front of the sea, that's an image of a weekend that we organize twice a year for people living with HIV, and for, I don't remember how many years already, we also collaborate together with HIV-SAM, so that people that you've addressed can also join in that weekend. And we've seen it grow year by year, that people participate in that weekend. Folders are developed for healthcare workers to help talk about HIV. And we try to include each other when we develop materials like that. See, our latest campaign that has run a couple of years, talks about HIV Stops Here, which role models were used. And also in those development, this is one of the versions of it that we try to address all communities involved. And this was one of the results of our research that we did for the needs for people living with HIV, so that what we do really services the needs that are expressed by our audiences. And also in that investigation that Gert knows very well because he performed it, that all different groups that are affected are as best represented in that survey. So what will happen from 2024 onwards? So how this works is that the Flemish government makes a contract on a certain topic, in this case, sexual health promotion. And so from 2024 onwards, this means that our contracts will be joined, and that we have a new assignment to develop a strongest possible plan for promoting sexual health among vulnerable migrants, of people with a migrant background, including people from sub-Saharan African countries. So far, HIV-SAM has focused on this group particularly. So that means that we will be enlarging the scope, that it's not only people from sub-Saharan African countries, but migrants in vulnerable situations. So that will be an important thing to prepare. And also, but you've seen it also, that Dungu explained it already, that there is a broadening of topics. It's not only HIV, living with HIV, or the prevention of HIV. That is the focus. It's also on sexual health. It's sexual health promotion. So those two lines need to be developed, and Dungu and Alexander will, of course, remain working towards the sub-Saharan African countries, but there will be two new people engaged shortly to help us address that larger task that we have been asked to do. What can you count on? Well, I hope I already told it a little bit throughout my talk, but we remain very committed to outreach work. Find it very important to be able to be in direct dialogue with the people we work for, and that what we do is an answer to a need and not just our need. So that also means that there is space for a peer-led approach. And at the same time, we will also invest in reaching or supporting our professionals that are surrounding the groups for whom we work, that make them more able to talk in a comfortable way about sexual health with all target groups. So, and the former slide, I already mentioned it, that our teams and target audiences will be described also in more detail, that we will have to focus on who we will address in what way. So in the meantime, I hope No, we will work to gain the trust of our African community. And we believe that in an approach in which the target group actively helps shape our activities. So that is our commitment, our engagement for this work, for our work that we have done already in the past as well. What does this mean over the time? Well, we started working together way before 2023, of course, but from that point onwards, we really started to focus on towards this point of today and of the next years to come, which means that because we have gone through so many stages and we have talked and shaped and invested in getting to knowing each other better and getting that contract going by our government, it also means that we can assure that until 2026, because that's the duration of the contract, that these things are assured. So that's also very important to underline. So starting from January, Dungu and Alexandra will start at Sensoa. We will be a new Sensoa together, and our policy worker and prevention worker soonly after. And since trees are the symbol of today, we've also have a tree that we like to use when we symbolize what it's like working for Sensoa, and how all levels of our policy levels, but also everybody, all staff involved, have an important role to play, because without one of these issues, well, that tree wouldn't last very long. So I hope this has helped a little bit to lower the threshold, and I thank you very much for your attention.
Okay, thank you very much, Sandra. Dear audience, since we are very late, I would like to ask you to keep any questions you have for the reception afterwards, because yeah, people also may have to leave and it would be a pity, really. So we are very happy that our director, Professor Lut Leinen, has agreed to conclude this event, and I think I don't have to introduce her, but I would also like to remind you that before you became head of the Department of Clinical Sciences and now director of ITM, you also worked with MSF, so you are very experienced also with community-based outreach work, I think, under the most difficult circumstances. Thank you.
Thank you. So I will be brief. If you ask me whether I feel safe now, I'm not feeling safe. So this is the least popular thing that I do, is talk in public, but I'm very happy to be here. My first encounter with HIV and AIDS was when I was a medical student in Congo in '84, so a long time ago. And at that time, I didn't know that it was HIV and AIDS, but beautiful young people were dying of a disease that we didn't understand. And it's only when I came back later as a student at ITM in '86 that I learned about HIV and AIDS. So in these 40 years already, so a lot of things have happened in the field of prevention, in the field of community participation, and especially in the field of treatment. I even learned from Dungu that it's normal to have a condom in your pocket. So who in this room has a condom in the pocket today? I want to acknowledge the role that Bob played in my life in terms of what I know about HIV, how to deal with people with HIV. And I think it's not, it's classically, typically for him, that the idea of creating something like a support group for people living with HIV is by Bob. In 1993, he said, okay, I'm going to find some funding. City of Antwerp had given a little bit to start up this support work for people living with HIV from sub-Saharan Africa. And I think since that time, many things have happened. And Christiana was just telling me the different roles that I had at ITM, but very often the question was asked, why do we continue to have this project at ITM, HIV-SAM? It's a support group, it's a patient group. Why is this at ITM? And I think the reason why it was important to have it at ITM, because it allowed us to better understand the needs of patients and the needs of that particular group. And many of ITM people have done research on looking how can we improve the care for this particular group. And I think this would not have been possible if it was not really embedded here at ITM. They often tell me now that it's very difficult at ITM to make choices, what to do and what not to do. It's always about how do you make choices. I think this time the government made a choice for us. They told us and Sensoa that the project HIV-SAM should now go to Sensoa. And I think it's a timely decision, but it will be a challenging project to realize, but I hope you will succeed. Because I think there is still a lot to do as well in people living with HIV from sub-Saharan Africa, but also in migrant populations in Belgium, but also for, and this, I always have to look at how it is LGBTQ plus population. It's a very difficult abbreviation. Yesterday, I was in contact with a PhD student of mine who's coming from Ghana. And she said, yeah, we have an issue here in Ghana. The parliament is discussing a bill to impose harsh penalties on LGBTQ plus people. And so I think this is really very sad because it hampers a lot the preventive measures or the preventive messages that you can convene. And I heard some challenges here also from how to deal with that. But so, and then a Ghanaian cardinal, Mr. Turkson, he mentions homosexuality should not be a criminal offense. People should try to understand what is happening there. And then she wrote me that this, for this person, for this cardinal, he will probably be crucified, not really, but crucified in the public opinion court, because he told this. And so as long as this is happening, and that will also be a challenge, I think Dungo was talking about beliefs. It's very difficult to discuss about beliefs. It's very difficult to discuss about how we think about gender, and so these things, they need to be discussed. And I think for that reason, it's a good opportunity that HIV-SAM and Sensoa are merging, are coming together, because it will also create opportunities to discuss these issues more in depth. And yesterday we had very nice talk. I don't know who because I was online, but it was Koen Peters talking about categories. We are always putting people into categories. And as researchers especially, you do research on this group, you do research on that group. And in fact, you cannot just split people in categories, because if you start asking questions, you may be very different, you may be different target groups, you may have different needs, but you also have a lot of things in common. And so if you ask simple questions of life, who has a partner, who has been ill last year, there is a lot of things that are common. So those are simple questions, but you can go much deeper than that. Another thing that he told, and what I found very striking, is if we all have to cope now with artificial intelligence and how to work, how to deal with that. And so he showed images that if you ask artificial intelligence that you have, that you want pictures of people living with HIV, they always give you pictures of people with a black skin. And so there is a lot of stigma still around. And I think by putting categories together, this may also help to understand each other's point of view and each other's challenges, because they all have challenges. So I think a lot of work is still to be done. It's not because we have treatment that there is no longer stigma. People still are afraid to discuss about HIV. And for that reason, I would like to thank the whole team, HIV-SAM team, Bob who founded it, but also all the people who have over the almost 30 years that it exists, worked on helping patients to understand stigma, to deal with stigma, to give support to each other. And also all the volunteers who contributed, because I think without the volunteers, the work of HIV-SAM would not have been possible. And so I think let's also not just think about HIV prevention, but also about the broader WHO definition of health and well-being, which also includes mental health. And I think mental health issues are causing a lot of problem once you have HIV, but also lead to risk behavior before you are HIV positive or have risk behavior. And so in that sense, I think the mission of SENSOA is very clear. They work on sexual health, and I think both target groups or all target groups, young people at risk, HIV-SAM, the migrants, the sub-Saharan African youth, they all will benefit, I think, from a joint approach to HIV in 2024. So thank you very much for your attention, and I wish you a very nice evening.
Okay, I would now like to invite you to go to the Caribou. So for those of you who don't know, it's across the street, and there will be a little reception, some drinks, and opportunity to network. Thank you. Ja, gaan we wegdoen.
Ja, dat kan.
Die werkt niet meer zo goed, hè?
Nee, ik moet echt hard.
Ja. Oh ja,
nee,
dat
nee.
timekeeping
Ja,
was
hè.
bedankt.
Ja, het is nog een minuut, hè? Ja. 3 minuten. Op.
Eens kijken hoe het is. Jij wilt ook, hè?
Ja.